So the talk that I was asked to comment on is pain relief, palliative care, and hospice. And to understand the topic of pain and palliative care and hospice services, we first must understand the terminology that we're using. Words that we use matter. What is pain? Pain has many different and varied definitions. All you have to do is Google pain, and you'll come up with a multitude of expert associations, and all sorts of opinions on what is pain. What most healthcare providers learn at some point along our journey in education in medicine or nursing is that pain is whatever the patient reports it to be. A common or simple definition given by the Oxford Dictionary states pain is the physical suffering or discomfort caused by illness or injury. Yet, as healthcare providers, we know pain can also be classified in many other ways. There's acute pain, chronic pain, high-impact pain, complex regional pain, or central pain. It can be further described as, or broken down in the physical way, of somatic or visceral pain, neuropathic or neurogenic pain. We can also then consider existential and biopsychosocial pains. But that in and of itself is another full conversation and lecture on what is pain. If we're further to break down pain, we can continue to talk about what is the concept of pain and suffering. And as pain comes with an element of suffering, that's also another conversation. As the topic of suffering is enormous, there's so many experts and many which have been brought forth already today. Philosophers, theologians who've written about the ages, across the ages, on the topic of suffering. And again, one who was already mentioned, our beloved St. John Paul the Great, who not only wrote about suffering and pain, but talked about redemption, the redemptive value of redemptive suffering and pain, and gave the whole world a real-life example of how to live with suffering until the end. And that's what hopefully we can do in palliative medicine and hospice care, is help people understand the role of pain and suffering in their lives and in their journey back to God. Despite how we look at pain or delve into the complexities of pain, what we certainly can agree on is that pain is universal. Everyone at some point in life suffers pain. I would venture to guess that in this room, almost all of us, if I were to ask the question, has anyone had or have pain? Everyone's arm would most likely go up. But to focus on it as a palliative care nurse provider and practitioner, what I focus for myself in my treatment of pain comes from my underlying Catholic essence, education, moral and ethical belief system in directing and delivering palliative care. So what is palliative care? I work in a hospital setting in Northern Virginia, and I work as an inpatient nurse practitioner in palliative medicine. And oftentimes when I'm introduced or brought into a patient's room or introduced or talked about, I get immediate fear and panic because a lot of people don't understand what is the difference between palliative care and hospice, and they immediately say, "Why are you seeing me? I'm not dying." So what is palliative care? As described in the Catholic Guide to Palliative Care and Hospice from the National Consensus Project for Quality in Palliative Care, as I found in some of the documents that I've used from the National Catholic Bioethics Center, palliative care is an interdisciplinary care system designed to anticipate, prevent, and manage physical, psychosocial, social, and spiritual suffering to optimize the quality of life for patients, their families, and caregivers. Palliative care can be delivered in many care settings through the collaboration of many types of healthcare providers with the focus of relieving symptoms and managing and assisting with goals of care in relation to their medical plan of care. So that may sound like a lot, and again, Joe has these wonderful documents that can help reiterate what I just said and where I took that from, but just explain a little bit more personally what I explain to patients when I see them in a consult. Palliative care will, again, look at the focus of treating symptoms of disease. So we treat patients from the beginning of a disease, potentially, until the end of life. And palliative care comes in and out of patients' lives according to the needs. In the hospital setting, again, where I work, symptoms sometimes are managed and changed by what I do, the medical orders that I put in a chart or manage for patients. Or sometimes I don't need to do that part because I'm working in the ICU with the ICU team, and the doctors there are managing those symptoms. So what I might be doing is addressing the overall goals of care and helping people to understand what are the effects of the medications ordered, what are the impacts that has on the disease process, and what are the decisions that the family has to make in those moments. So again, whether it's in the ICU setting or the cardiac unit or the oncology unit, across all spectrums of chronic and acute disease, palliative providers can help to manage symptoms for patients' comfort, as well as clarify goals of care. Hospice, on the other hand, so palliative, as we come in and out of people's lives across the healthcare spectrum and across the journey of life, we will help again to palliate, to comfort, to offer support for different symptoms that patients are having. That's very different than providing strict comfort care or hospice services. All right, palliative medicine is applicable again from the beginning of disease to the end of the disease. So for example, a cancer patient may come in with tumors, and those tumors are pressing on organs or nerves in the body that are causing pain. I may help that patient address the symptom of pain that comes from the tumor. Another cancer patient comes into the hospital because they have nausea and vomiting from their chemotherapy. They still want to continue with all their chemotherapy, but their life is miserable because they can't manage their nausea and vomiting. So I may help them address the issues of dealing with their nausea and vomiting so that they can then return to their treatments. Other patients and other reasons for palliative care can be end-stage heart disease, end-stage pulmonary disease, end-stage kidney disease. Almost any chronic disease can be alleviated and ameliorated and palliated through palliative care. There are specific rules and regulations for reimbursement. As we know, the almighty dollar always has a hand in healthcare. So there may be times when it may not be reimbursable in the outpatient setting, but most insurance, Medicare, Medicaid, most of those will cover some form of palliative care if it's appropriate for the symptom at the time that it's being recommended. Hospice services are different. Hospice services are appropriate in the last stages of a person's journey in life. Typically in the very beginning years of hospice, there were very firm rules and regulations. Hospice was, you had to have a diagnosis that within 6 months you were absolutely no longer going to be here on this earth, you were going to die. And typically there were a lot of rules saying that you had to stop doing things, right? You had to stop. People understood hospice, that once you went to hospice, you were basically dying and you just stopped everything and they gave you morphine and that was it. Rules have changed over time. There is still a requirement or qualification that if you have a disease process that within the natural progress or progression of that disease, your life could naturally end in about 6 months, then you have a qualifying factor typically for hospice. After 6 months, years ago, again in the very beginning, hospice would walk out the door at exactly 6 months if you did not die. And in fact, they might have encouraged you to die. Nowadays, that doesn't happen as much. You can walk away from hospice if you don't want it anymore. You can graduate from hospice. You can go still to the hospital. It used to be in the old days you couldn't go to the hospital. So some of the rules and regulations have changed, and although they're not always understood well, there are definite benefits to understanding your particular situation and what the goals and philosophy are in that moment. So that people accepting hospice really have to understand what they're accepting. And Joe, I think, has some other information, and we can both talk a little bit more about hospice. But typically, when people, at least in my experience, when I encourage hospice, it's because people need more of a support system in the end stages of their life. And that could be at 30 years old, dealing with metastatic disease that there's no more treatments for, or that the patient just can't survive the course of treatment. And so therefore, with a 30-year-old heart, they may live longer than 6 months, but things around them are such that they could benefit from this hospice benefit. I might encourage that and say, here's a team of people that can support you more in your home if your goal is to stay home. And you could benefit from that, possibly. But again, you have to be the one, and you have to remember, just like in your health care forms, your post forms, your advanced directives, any of those forms, you have to be the one directing what's being done or what your wishes are. I've also found in the healthcare setting, in the hospital, and this is probably quite natural and normal, we sometimes, especially if we're the sick one, give up our decision-making process. We become afraid. Oh, the doctor's in charge. The doctor or the nurse practitioner, they know the answers. They know what's the best for me. And we don't always stop to step back and think, is this really the best for me? Do I really have all the information to make this decision to not seek a PEG tube or to not continue with my treatment? Or am I just sort of being bombarded by information that I don't understand? So one of the most important things that I try to help people with is to empower them to understand and have that informed consent. So hospice is a fully covered benefit, Medicare, Medicaid, and insurance. It's regulated by the government. It consists of a team of providers, usually a nurse, doctor, nursing assistant, case worker, social worker, a chaplain. It's an interdisciplinary approach to dealing with the process and the journey of the end of life. One of the most important things that we can do in palliative and hospice medicine is accompany our patients along that journey. I recently heard a homily by a lovely hospital chaplain who said, we can't always cure, we cannot always extend life, but we can always offer healing. And that may not be a healing of the actual disease process itself, but we can participate in accompanying that person along their journey to healing, journey towards their final destination, all of our final destinations. It's a great honor for me to work in the field that I work in. I'll tell you a little personal story more so from my bio. I was initially working in the field of HIV and AIDS, but I had always wanted to be a midwife. My whole career, I knew from forever that I wanted to be a nurse. And when I first started nursing forever ago, we had to start on a med-surg unit to get the experience that we needed to then go off and specialize. And so my goal was to work in med-surg for just a year and then go off and start with babies and start in the NICU and OB and then eventually become a midwife. And in the midst of the HIV and AIDS story, history, drama, tragedy in New York, I was working at the bedside of all of these patients who were dying. And I found strength and comfort in my faith and in the gift that my family has given me. I came from very strong Catholic, well-formed, Jesuit-formed back in the day, parents who instituted and lived their faith in our family life. And so I felt comfortable in understanding what was happening in the people that were dying around me, and I knew that there was a better life for them. And in being able to stay there, I sort of realized I just can't leave this to go off and be happy delivering babies and learning about babies. There was such a need in the times to stay at the bedside of these people who were dying. And that was really God's plan for me in the long run, because after I got through that, I thought, okay, now I can go back. Now I can go be a midwife. Now I can go do what I want to do. And unfortunately, or fortunately, my journey led me down the path of where I am today, which is a nurse practitioner in palliative medicine and hospice. And I've only been a nurse practitioner for 6 years. I started off wanting to be a family nurse practitioner, again, thinking I'd go back to babies. But in realizing, again, the needs, I changed and studied to become an adult geriatric provider. And that's what's allowed me to work in the field of palliative medicine. In adult geriatric medicine, we are living in a society and in a day and age where we are that and probably all of us in the room, are that sandwich generation, where we still have children that we're taking care of, but we're also taking care of adults, of our parents, or of our older siblings, or of someone that's still here present in this world and elderly. And I realized that the geriatric provider can also offer that life-giving support. And so rather than being a midwife of babies, sometimes, especially in the midst of COVID, with all the death and dying that happened, I found and sensed a vocation to be sort of what a hospice nurse wrote a book called Midwife of Souls, which I was fortunate to read once, and I'm blanking on her name, the author of that book, but I would recommend it to anyone. It talks all about the beauty and the gift of hospice if it's done in the right way, from a Catholic or Christian moral perspective. But in the long run, I do feel that I'm a midwife, just now, hopefully, into an eternal life with God in heaven. I don't know about that. Again, in palliative medicine, we just have to treat symptoms. Patients have to have symptoms that can't be managed, and so we come in to specialize and focus in on those treatments. So people have progression of disease throughout the years, but if they have an unmanaged symptom, for example, cancer again, a lot of oncology physicians these days don't necessarily have the time or interest in the in-between visits. And I shouldn't say interest, I'm sure every oncologist that's working with their patients is very interested in them. But they're so busy doing so many things that a patient in between visits who has a question or a concern or a problem may not be able to see that oncologist until their next visit. If it's a problem that can be alleviated through palliative medicine, then we can either see them in a clinic setting or see them in a home setting and help to manage that, to assist the oncologist so that they can then continue to be comfortable until their next meeting with the doctor. Yeah, home care. Yeah. Right. Right. Right, and home care and palliative can go together. Home care services, meaning the Medicaid benefit or Medicare benefit after hospitalization or after acute change, right? So you go to the hospital and for whatever reason you're very weak coming out of the hospital and you just can't function the way you were prior to that. You want to go home and the hospital will send in a home care team of PT, OT, speech, and nursing to help care for you, to get you back stronger, because the whole goal is that your insurance, Medicare, doesn't want you to be rehospitalized. So they're going to pay a program to help you get stronger, hopefully at home. That coincides, and that's okay also with palliative medicine, because palliative medicine, again, is managing a symptom of a patient who's in treatment usually. Hospice has a different approach, because they know that those treatments are no longer effective. So, of course, the government's going to pay for you to receive hospice, because they don't want you to ever go back to the hospital. And in some cases, that's a good thing. In some cases, it's not. So that's where, again, I have to encourage every person, every family, to have the informed consent of what am I getting into with this hospice? What is my understanding of what they're going to offer me and do for me or not do for me? And how can I use this Medicare benefit to my benefit that meets my moral belief system?
So I'd kind of like to focus more on some of the challenges, things that we face and things that you may or may have already faced. But again, just a quick little review. So palliative care and hospice, they're similar but different, right? Palliative care, generally speaking, it's focused on symptom relief and other things, but really symptom relief, but that can be in any, you don't have to be terminal, certainly, to accept palliative care. Whereas with hospice, 6 months or you're diagnosed 6 months or less to live. So a lot of people will describe hospice as palliative care for those who are terminally ill. So that's just a kind of a way to keep them separate. What are some of the issues, however, that we run across? And this part of this presentation comes from really from our experience, again, fielding consults at the NCBC. So what are challenges with some hospice providers? And I underscore some because I've done this presentation in other places, and there are hospice physicians and palliative care physicians who have gotten upset saying, we don't do these. And I said, I know. And that's why I underscore some, right? There are very good hospices out there. We don't get calls about them, though. I mean, that's what it comes down to. So what are some of the challenges that we have run into with some of the hospice providers that people will run into? First of all, oh, here we go. There's Max doing their things again. Okay, whatever. One of the things that we hear from people is that a hospice, as soon as someone is enrolled in hospice, they will basically tell the family, well, you know what? We're going to remove all medications. No more medications, all right? And that can be just a couple of bullet points there. Now, to be fair, all right, and doctors have said this, that if someone is enrolled in hospice and they've got 20, 25 prescription drugs that they're taking every day, well, if we know that we're in an end-of-life situation, are all of those medications necessary? And the answer is, in many cases, probably not. What can we remove? That's one thing. That's not the challenge that people come to us with. They will say, this hospice told me that, if my loved one is enrolled, all medications are gone. And you're like, whoa, what? Right? So again, things to be aware of. Secondly, in terms of pain management, I had a whole section on pain management that we're not doing, but kind of two ends of the spectrum here that we run across. One is, complaints that we've got from people is that the hospice that their loved one is enrolled in doesn't monitor their loved one for pain. People just sort of leave them alone. And they're in great pain, but nobody does anything. All right, so that's a concern. On the other side, there are those who will say, we enrolled our loved one in hospice. Our loved one wasn't experiencing any pain whatsoever, yet they immediately started them on X, name X, whatever that is. And oftentimes it's some sort of an opioid or something else. So it's like, well, why? Why did they say? We don't know. And so what we'll tell people is you make very clear to the hospice that if my loved one is not experiencing any pain, don't give them any pain medication. They don't need it, right? We'll also hear, again, we're hearing this from people who call us up, but there's actually data on this as well too, in terms of some hospices will, to keep their patients calm, they'll medicate them or over-medicate them to do that for the express purpose of keeping them calm, all right? So things to keep in mind. In terms of on the nutrition and hydration side, you can kind of see where we're going because we already talked about this. We'll hear from people who will say their loved ones, when they went into hospice, the hospice told them that, well, as long as your loved one can eat on their own, we'll provide them with food, but once they stop doing that, they don't get anything. And you're like, what? We're like, yeah, they just don't get anything. So no feeding, no hand feeding, right? Or, again, the refusal of any kind of medically assisted nutrition and hydration, or even an IV, even when they're indicated. Now, again, at end of life, there's a lot of, when the person is dying in days, they don't need, again, as much food. They don't need as much water. We recognize that. But there are categorical, when hospices say, we're just not going to feed you. And we hear this. We hear this all the time, particularly with dementia patients, as I mentioned this morning. It's one of the toughest ones, toughest cases when a dementia patient has forgotten how to swallow or forgotten how to eat, right? What do you do? What do you not do? And people run into this challenge with hospice all the time. And again, if you don't feed someone, what's going to be the result? Or if you don't hydrate them, what's going to be the result? Death. Yeah, the person is going to die. And I know doctors, and it's not George, but I know doctors who have said to me, Joe, I'll tell you right now, I don't recommend my patients go to hospice, because when my patients have gone to hospice, they don't feed them. That's stealth euthanasia. They don't even recommend it anymore, right? And this is something that we're dealing with, fairly often. And again, none of this is meant to scare people, but just be aware of what's going on. There are very good hospices. There are hospices I've talked to, they just happen to be Catholic hospices, surprise, surprise, that said, yeah, we'll take a patient with a PEG tube. Yeah, absolutely. And that's another one. There are hospices that will refuse to take a patient who has a feeding tube, right? This is what we're running across here. Palliative sedation is another issue that sometimes we will run into, and basically it's you can see what it is. Basically, the patient is through medication remains sedated. Now, the Catholic teaching on this very quickly, and we could talk more about this. I'm just trying to highlight some things. Catholic perspective is that patients should be able to maintain consciousness to the greatest degree possible, and the reason for that is so that they can prepare for their death, so that they can, say their goodbyes to their loved ones, get their affairs in order, most importantly, receive the sacraments of the church, be reconciled to God if need be, right? There are certain situations where possibly a palliative sedation could be appropriate. They're very, very rare. But we've got some references on that if you're interested. But generally speaking, all right, patients should be, to the extent that they can, right, they should be conscious so that they can prepare for end of life. This is a big one as well. What we have found and what we're seeing more and more, we've actually got some podcasts on this. There's a great podcast we did with a palliative care physician named Nicole Sharilla. She practices at the Ohio State University. I always have to say that because they want me to. But Nicole tells the story of she was in her palliative care residency in California when California legalized assisted suicide. And what the organization she was doing her residency with, she's a very faithful Catholic, said, oh, by the way, hey, assisted suicide has just been legalized in the state of California. Palliative care, you guys are the ones who are going to administer it. Write a policy. And she said she knew she had to get out of California, which she did. The problem here is that organizations like Compassion and Choices, that's the big assisted suicide promotion organization based out of Oregon. They used to be called the Hemlock Society, but then they changed their name. Compassion, and again, euphemisms. We were talking about euphemisms a little bit earlier today, right? They support assisted suicide, but you can't say assisted suicide. It's Compassion and Choices or medical aid in dying. Again, it's BS, all right? What's happening and what we're seeing is palliative care organizations, as well as hospice organizations, are what they will say opting in on assisted suicide, right? So they will offer it or they will do it. Compassion and Choices says very clearly that palliative care includes assisted suicide. That's palliative care. That's how we care for people at the end of life. We help them kill themselves, right? And that's where we are with all of this. Right, so these are some of the challenges that you're going to face, not only with hospice, but with palliative care. So one of the things we did a few years ago, we wrote a document. It's actually out there, and I brought a few copies of it. And at the end of the day, if people would like them, you're more than welcome to take them. But they're available on our website as well, and I can email it to you. But it's a Catholic guide to palliative care and hospice. And it kind of runs through some of the things we talked about, what's palliative care, what's hospice. But there's an insert that's titled Questions to Ask Before Enrolling a Loved One in Hospice. And I remember when we put this out, there were some people within, like higher ups in Catholic healthcare, for Catholic healthcare systems, who I was talking to them and they said, Joe, I saw this. I saw what you guys put out. I love this. I wish I had this when my own mother was, at end of life. But if you are thinking about enrolling a loved one in hospice, there's a series of, I think, 14 questions. And I'm just going to put them up here. And we'll say we got a little bit over 5 minutes or so. But you'll see It's going to raise some questions, I hope, for you. It's going to actually address some of the issues we've been talking about today. But these are questions we think you should ask any hospice provider before you sign on the dotted line. And don't try to write them all down, because they're kind of long. Unless you're shorthand, unless you can do that, that's good. I'll send it to you. I'm happy to share all of the stuff with you. So the first couple of questions are a bit innocuous, or a little, well, maybe more so than some of the later questions. Question number 1, when was the last time this hospice was reviewed or accredited? What were the results? And what is the status of the hospice's license? You ask that question up front, you're going to get somebody's attention. They're going to be like, ooh, this person. Somebody in the Q&A say, Joe, tell us about what you tell patients when they run into issues in the hospital. I love telling this story. It's good stuff. All right, but that's the first one, right? Tell me about your licensure. Tell me about your accreditation. Are you accredited? Secondly, will this hospice provide reference from either prior patients or their family members or any oversight or accrediting organizations and these references that can be verified? Give me some references. Let me see what people have said about you. Now you really got their attention. Thirdly, what is the hospice's communication policy, particularly with regard to the patient's surrogate decision maker and family members? Does the surrogate and family members have access to the patient and staff 24/7? In other words, if I need some information about my loved one from the hospice, how do you provide it to me? What's the process? Right? Fourth, what training does this hospice offer for family members on the administration of medications and the use of equipment? This is going to be mostly for in-home hospice. All right, so if you're providing care in-home. If one's loved one is in a nursing home or a hospice facility, this is probably less of an issue. But from what I understand, there's more and more and more. There's a move more towards home hospice, particularly for people who want to die at home. How do you train family members to administer medications, do the various things? Fifth, here's a big one, because we hear this all the time. It's 2 o'clock in the morning and something's happening with my loved one. I call hospice. No one's there. What procedures are in place to assure that the hospice is not short-staffed so that a nurse or other caregiver can be summoned by the patient or family when needed? How do you assure that we get that? You assure us that you give us the help that we needed. What policies or procedures are in place to make sure that happens? You think you got their attention by now? Some of them may be starting to throw you out. It's like, you might want to go. It gets better. 6, does this hospice provider have access to spiritual care services, particularly Catholic clergy, to administer the sacraments? Hopefully, if it's a Catholic hospice, the answer is yes. Right? Hopefully, if it's not a Catholic hospice, the answer is yes. 7th, will this hospice treat infections with antibiotics? This is really the ordinary, extraordinary question, right? The antibiotics is really just an example, right? Because if you ask a hospice, will you do ordinary care? They're not going to know what the heck you're talking about, at least from the Catholic perspective. They're not going to understand what you're talking about normally. Will this hospice treat infections with antibiotics? Will it continue to administer prescribed medications for chronic illnesses? Right? Yes or no? Tell me your policies. Tell me your procedures. 8, does a hospice accept patients on dialysis? That's another one we hear. If you're on dialysis, no, we don't do that. Will it continue dialysis if renal failure is not a patient's terminal illness? Get a question, get an answer to that. Be interesting to see what they say. 9th, will this hospice begin? George. Right? George talked about, pain medications with hydration versus pain medications without hydration. Will this hospice begin an IV if necessary to administer medications or hydration? If not, what procedures in place to assure that patients receive an IV if indicated by the patient, surrogate, family member, or physician? How do you do this? Do you have to transfer somebody to the hospital? What do you do? What's the procedure? How do you do this? 10, what experience does this hospice have with patients suffering from dementia? Aha. What's your policy about feeding patients with dementia? As I mentioned it before, this is a huge, huge issue. 11, does this hospice accept patients with a feeding tube? For a lot of them, the answer is going to be a categorical no. Interesting. How do they eat? How do they get nutrition and hydration? Will it establish a feeding tube? Now, probably most hospices aren't going to do that, again, because it's a medical procedure, right? But maybe the question is, will a patient be transferred to a hospital if they could? Now you're saying, well, we're getting off the purpose of hospice. So there's a lot behind this question. There's a lot of things that need to be discussed, but it's really the question about nutrition and hydration, right? How do you assure that patients, assuming that nutrition and hydration is going to be beneficial to them, it's going to accomplish the end for which it's given, how do you make sure that my loved one receives nutrition and hydration? By this point, the hospice director is probably pretty uncomfortable. But that's a good thing. Unless it's a good hospice. Then they go, oh yeah, we do this, we do. 12, what's the hospice's policy on pain management? What monitoring system is in place to determine the effectiveness of pain control? What criteria determine the administration of pain medications, right? Ask them these questions, right? This is your loved one. 13, under what, if any, circumstances would terminal sedation be used? How does this hospice respond to requests for assisted suicide or voluntary stopping of eating and drinking, as we said before? If a patient says, I want to end my life, what is your response? How do you do that? And again, we have some resources, a number of resources available there. The questions are meant to start conversations with hospices. And again, are all hospices going to answer those questions differently? Yes, all right? Some will answer them maybe better than others. And what you can do is take the information that you get from the answers to these questions to make a determination, is this a place that I can entrust with my loved one's life? Or is it not? Right? And that's why we have that available to you. So again, I don't want to, it sounds like I'm trashing on hospice here. I don't mean to. I really don't mean to. Right? There are very, very good hospices out there. There are very faithful hospices out there. But there are also the other side of the coin as well. And one of the things, and maybe Eileen, we could talk about this in the Q&A, I believe what's happening in the hospice world is, whereas a lot of it originally started out as non-for-profit, they're moving to for-profit. And when you move from, for-profit hospice care, but when that happens, you can see when some of the challenges come up.